Good morning and good afternoon. I'm Victor Zhao, the President of the National Academy of Medicine. It's my distinct pleasure to welcome all of you to the 51st National Academy of Medicine annual meeting. Thank you for spending your Sunday afternoon or morning in the West Coast with us. For members of the public who are joining us for the first time and may not be familiar with the National Academies, let me tell you a little bit about who we are. We were chartered by Congress and President Abraham Lincoln in 1863 as an independent advisor to the nation on matters of science, technology, and health. Over the years, we've gained a reputation of providing independent, science-based, and trusted advice impacting the nation and the world. The National Academy of Medicine have distinguished members who are at the forefront of discovery and progress in health medicine and the biomedical sciences. Held every October, the NAM annual meeting is the gathering of our distinguished members and the most important meeting of the year for the organization. Now, COVID has created immense challenges for all of us over the past 20 months, but it's also offered opportunities to innovate and adapt. So last year, for the first time, we decided to conduct the meeting entirely virtually and open our interest group meetings to the public. This approach was really quite successful. We decided to continue it this year. Now, the interest groups bring together NAM members from a variety of disciplines and sections to enrich the understanding and to engage in dynamic conversation on pertinent scientific and policy topics. You know, the program is driven totally by the NAM members. All interest groups meet during the annual meeting. They may develop new ideas for program activities or other initiatives by the NAM and assist membership sections in the discovery of outstanding candidates for membership, especially younger individuals working in interdisciplinary or emerging fields. In fact, I've been so impressed with the enthusiasm and engagement of members in the interest groups and the quality of interest group programs that I'm thinking of making the interest group program as part of the official scientific program every year in the future. So please stay tuned. So I hope you join the scientific program tomorrow. We have an outstanding program in store for all of you. The theme of this year's program is Crossing the Policy and Equity Chasm, Lessons Learned from Compounding Health Crisis. And it will focus on the importance of science-informed policy to address existential, persistent health threats and inequities of COVID-19 and climate change. So it's going to be a great event with the keynote opening from Dr. Eric Lander, President Biden's science advisor, Director of the White House Office of Science, Technology, and Policy, and a member of the President's Cabinet. In addition, there will be a number of distinguished speakers and leaders. Towards the end of the scientific meeting, the Secretary of Health and Human Services, Javier Becerra, will deliver a closing keynote. After the scientific meeting, I'll chair the President's Forum, which will formally discuss the NAM's Grand Challenge on health, human health, and climate change. The forum will kick off with an opening keynote address from Gina McCarthy, the White House National Climate Advisor. The scientific meeting will begin promptly at 10 a.m. Eastern Daylight Savings Time, and I hope I'll see you all there. And now over to the interest group session. Thank you.
Well, welcome everyone. I'm Judy Wasserheit, and I am delighted that you are all here. I think we have quite a stimulating and provocative session ahead of us. Thanks for joining, and Amechi, please, let's get started. Good morning, good afternoon, and good evening, depending on your Zoom point of origin. I'm Judy Wasserheit from the University of Washington, where I chair the Department of Global Health and co-chair our Alliance for Pandemic Preparedness. I have the honor of being the chair of the National Academy of Medicine's interest group on global health, infectious diseases, and microbiology. And on behalf of my two very wise, witty, and wonderful friends and vice chairs, Mike Cohen and Patty Garcia, as well as myself, welcome to this session on COVID-19 and the way forward. What happens when a species has been immobilized? As some of you may remember, when we Zoomed together almost exactly 1 year ago for our annual meeting last October, it was about 9 months into the pandemic. Vaccines weren't yet available, but were well on their way. And SARS-CoV-2 had infected almost 40 million people around the world and killed more than 1 million, according to national surveillance systems. Although we recognized that these were likely to be gross underestimates of the devastating direct health impacts of the pandemic at that time, and that these estimates didn't even begin to reflect the equally devastating and potentially longer lasting educational, economic, and social impacts of the pandemic on individuals, families, and communities. Despite these mind-numbing impacts, there was actually a cautious sense of optimism among some, perhaps in part because of the unprecedented speed with which research was delivering vaccines and other interventions. So we focused on the path to reopening in the COVID-19 pandemic. We discussed lessons from 4 continents and explored emerging research on new and promising interventions. In reality, last October marked the beginning of major surges in cases and deaths in the Americas, Europe, Africa, and the Eastern Mediterranean. The Delta variant was also first identified in India last October and subsequently spread explosively around the world. As of today, globally, the virus has infected more than 236 million people and killed almost 5 million, almost an 8-fold increase in cumulative cases and a 5-fold increase in deaths since last October. The good news is that reported cases and deaths have finally begun to decline globally, although Delta surges are still continuing in some countries. It's likely that over the next 12 to 18 months, the COVID-19 pandemic will shrink in size and scope. The health impacts will be more and more limited for populations with access to care, and SARS-CoV-2 infections will become endemic. However, the COVID-19 pandemic has compromised daily life in every country on this planet. It's shut down schools, businesses, travel, and trade around the world. Many people haven't been able to hug grandkids, parents, siblings, or friends for many months. I think I'm not alone in initially grossly underestimating the wider societal non-health, or at least non-direct health impacts of the pandemic. Many of these impacts will have long legs. Indeed, some are likely to have far more far-reaching effects than the direct health consequences themselves, particularly for those who are already marginalized because of poverty, race, ethnicity, gender, and other factors that divide us. So today, we're going to consider the profound, multifaceted implications of the prolonged social isolation and disruption human beings and their societies have suffered from the COVID-19 pandemic. Our 4 distinguished panelists will get us started with 15-minute presentations during which they'll discuss what we know about these impacts to date and offer provocative predictions going forward from 4 critical perspectives. First, Chris Murray will discuss the effect of the pandemic on human health and the global burden of disease. Next, Jaime Saavedra will talk about the effect on our educational systems and long-term impacts on our children. Then Stephanie Siegel will share her insights about the effect on the global economy and how we might expect recovery to unfold. And finally, we'll turn to Erica Charters, who will help us look at what history does and does not tell us to expect. What lessons can be learned from epidemics in earlier eras? Then we'll shift gears, and Patty Garcia will moderate what I am quite confident will be a very stimulating Q&A session and discussion. And finally, Mike Cohen will bring us home with a brief synthesis and closing comments. This is the second year that the National Academy of Medicine has convened the main meeting and interest groups via Zoom. And we're also delighted to welcome for the second time the public audience to this interest group. And a large number of people have already registered to join us. So building on what we learned last year, here's how this is going to work. National Academy of Medicine members, please type your questions and comments into the chat box. If you really want to ask a question or make a comment verbally, please still type the basic question into the chat box and indicate that you want to speak by also typing unmute in capital letters, and we'll do it. This will help Patty aggregate related questions and comments so that we can get to as many people as possible. For our public registrants, you'll be viewing the meeting as a webinar, and live comments by chat, audio, or text are not available in this format. However, if you have any comments or questions for anyone on the panel, we very much want to hear from you. So please send them to the email address that's listed on the webinar page and is also being posted in the chat. Your comments and questions will be collected after the meeting and sent to the appropriate panelist. Now, let's get started. I'm going to give brief introductions for all of our distinguished panelists and for Patty and Mike now so that I don't interrupt the flow. Chris Murray is Chair of Health Metrics Sciences at the University of Washington and Director of the Institute for Health Metrics and Evaluation. He's a physician and health economist who has led the development of a range of new innovative methods and empirical studies to strengthen health measurement, analyze the performance of public health and medical care systems, and assess the cost effectiveness of health technologies. During the pandemic, Dr. Murray and his colleagues at the Institute for Health Metrics and Evaluation have provided projections of the impact of the pandemic on the global burden of disease as well as on health systems capacity in the United States, which have been widely cited by policymakers across this country and around the world. Jaime Saavedra is Global Director of Education at the World Bank, where he previously directed poverty reduction and equity and was acting Vice President of the Poverty Reduction and Economic Management Network. He rejoined the bank after serving as Minister of Education in Peru from 2013 to 16. An economist by training, Dr. Saavedra has led groundbreaking work in multiple areas, including poverty and inequality, employment and labor markets, and the economics of education. And over the last 20 months, he has added work on the impacts of COVID-19 to his portfolio. Stephanie Siegel is a senior fellow at the Center for Strategic and International Studies, CSIS, where she's focused on economic competitiveness, US-China economic relations, and the role of international financial institutions in the global economy. Until 2017, Ms. Siegel served as co-director of the East Asia Office of the US Department of Treasury, having previously worked in the Western Hemisphere, South and Southeast Asia, and international monetary policy offices. She also served as a senior economist at the International Monetary Fund, where she covered a range of emerging market and advanced country economies. Like others at CSIS and many of us here today, she's recently pivoted to focus on the pandemic. Erica Charters is Associate Professor of the History of Medicine at Oxford, where she also is Director of Oxford's Center for the History of Science and Medicine and Technology. Dr. Charters is an expert in the history of war, disease, and bodies, and is currently coordinating a multidisciplinary project on how epidemics end. Her recent article on the history of science and medicine in the context of COVID-19 provides an excellent springboard for our discussion today. Patty Garcia is a professor in the School of Public Health at Cayetano Heredia University in Lima, Peru. She is the former Minister of Health of Peru, Dean of the School of Public Health at Cayetano, and former Chief of the Peruvian National Institute of Health. An infectious disease physician and epidemiologist, much of Dr. Garcia's research has focused on sexually transmitted infection, including HIV, particularly human papillomavirus and cervical cancer, as well as reproductive health and medical informatics. During the pandemic, she's played a leadership role in multiple clinical trials in Peru and more broadly in the response to COVID-19. And finally, Mike Cohn is a professor of medicine, microbiology, and immunology, and also epidemiology. He is Associate Vice Chancellor for Global Health and Director of the Institute for Global Health and Infectious Disease at the University of North Carolina at Chapel Hill. Dr. Cohn's research has focused on the transmission and prevention of HIV with special emphasis on the role of sexually transmitted infections. Over the last 18 months, he and his colleagues have been a critical part of the COVID prevention network in conducting trials of monoclonal antibodies and other interventions. So, as you can see, we have an outstanding set of speakers for this session. And with that, I'll turn this over to you, Chris, for our first presentation. All right, Mechi, can we segue to Chris's presentation, please? There we go.
So in this presentation, I'm going to walk through the evidence on what have been the impacts of the COVID-19 pandemic. And I will briefly give comments in these 5 areas. And let's start with the simplest aspect of how much COVID infection has there been, how do we know, and what's that pattern look like worldwide. So the way at IHME that we look at the pandemic is illustrated here for Florida. We do this sort of analysis for about 500 or 600 different jurisdictions. That is either national level or subnational for larger countries. And this summarizes a lot of data. The top left is reported cases in green. Over on the next side on the left is reported hospital admissions in blue. And then in the bottom left is reported deaths in red. And those are all inadequate measures of what's happening because not all infection cases or infections are reported. Hospitalizations only get at the severe cases, and of course, deaths only get at a fraction of infections. And so the way we put this together to understand infections around the world is we use seroprevalence data. Here illustrated for Florida on the bottom right, the purple points are seroprevalence data corrected for waning sensitivity of antibody tests. Don't have time to go through that in detail. And in the middle column is the empirical estimates of the infection detection rate, the infection hospitalization rate, and the infection fatality rate. So we put all that data together and get the top right, which is our best estimate of daily infections by triangulating on cases divided by the infection detection rate, hospitalizations divided by the infection hospitalization rate, and deaths divided by the IFR. So we put that together for each location. We update that weekly. That's posted on our website as part of our analysis. So that's how we come up with this view of estimated global daily infections. And roughly the pandemic was running about 5 million infections a day from June of 2020 right through till late January of 2021. We started to come off the Northern Hemisphere seasonal peaks and got down to as low as about 3.5 million infections a day. And then the Delta variant showed up and created enormous transmission in particularly India, leading to a peak of over 15 million infections a day. We've then seen Delta waves elsewhere, leading to that peak up to August. And now we're currently in a phase of declining transmission. More on that later. When you put that location by location analysis together, this is the map of the fraction of the population that has been previously infected. And you can see really high levels of past transmission in Mexico, in Brazil, in Ecuador and Peru, in the Russian Federation, in all of South Asia, and in Southern Africa, and then some parts of the Middle East. There are places where we just don't really believe the data. They stand out on this map: Nicaragua, Venezuela. No data actually being meaningful data reported for Tanzania or Turkmenistan. But generally, we think this pattern is a reasonable reflection, with those exceptions, of where there has been a lot of transmission and where there has been much less. The biggest question mark remains sub-Saharan Africa outside of Southern Africa because of the absence of many seroprevalence surveys, which has been a really unfortunate gap in our knowledge. What about death from all those infections? Well, the way we look at this first is by looking at excess mortality. For more than 200 jurisdictions, we have weekly or monthly death, and those are the basis by which we estimate, by comparing using an ensemble of models, what was expected each week or month based on data back to 2010. This data set includes some LMICs, not as many as we would like, but certainly there are some. And the recent availability of civil registration data for a number of states in India has certainly helped us understand the magnitude of the Delta surge there. Of course, those data do need to be corrected for under registration, as is true for some of these data for other LMICs as well. Now, we then have the challenge of figuring out what excess mortality might be in the places without this direct weekly or monthly measurement, which would include most low-income countries where they don't have complete registration of deaths. And for those, we've built a statistical model, and that has things you'd expect to be in there, like seroprevalence, reported deaths, the infection detection rate, and then a host of variables that might affect the likelihood of identifying a case and how well they're treated. Universal health coverage, hospitalization rates, prevalence of diabetes, prevalence of obesity, smoking rates, and a host of other variables. And many variables come out to be predictive in this analysis. And at the end of the day, we come up with a predictive equation that seems to be quite good, using out-of-sample predictive validity with about, on average, an 8% error. So what do we find out? Well, we find that there are, up to the beginning of October, about 5 million reported deaths, but excess deaths are probably in the order of 14 to 15 million. So many more deaths. This is driven quite substantially by great underreporting in places like India that had very considerable transmission and associated death. So, because we're estimating for places without the direct measurement, there's a lot of scope for being wrong. But as a rough order, we think that there is many, many more deaths from COVID, from the pandemic, than the official reported data would suggest. A much trickier challenge is to say what fraction of the excess mortality is due to the virus, and how much is due to other pandemic-related changes in behavior, deferred care, a long list of possible mechanisms. And so we've used some statistical models. These are far more uncertain, to try to estimate that and come up with our best estimate of about 9 million deaths are directly due to COVID, which implies maybe as many as 5 to 6 million deaths due to other factors related to the pandemic. Now, here's a map of estimated excess death rate. And the biggest impacts in terms of death have been in the southern United States, Mexico, much of Ecuador, Peru, many states in Brazil, southern Africa, and then very much in Eastern and Central Europe, southwestern Europe, Spain and Portugal, and then many parts or many states within India have had excess mortality rates that are in the higher end of the spectrum, with much lower death rates in some select countries. Canada stands out given the contrast across the border with the US, but there are many examples like that: Norway, Finland, Australia, New Zealand, as examples of so far low excess mortality rates. Well, what about those other pandemic-related mortality? So the WHO definition is sort of anybody who's PCR positive or equivalent tests, and there have been detailed data audits looking for this sort of information on death certificates for a number of countries, including Peru, Mexico, and the Russian Federation. And those suggest that not all of excess mortality, particularly in the Russian Federation, is related to directly to the virus. And that leaves open this idea that I mentioned before, that there's considerable mortality from other causes. But we have a real problem just finding what those other causes are. There's a number of published studies that suggests in a particular place what causes may have gone up, but more systematic evidence is still early days. There's only about 10 countries where we've been able to get 2020 cause of death data, and those do not reveal a very convincing pattern across countries. The one part that is convincing is the marked reduction in flu and measles deaths, and then a more mixed bag around reductions due to RSV. And so those reductions seem very real, but which causes went up to account for the 5 to 6 million other pandemic-related deaths, we'll probably have to wait till we get much more cause of death data for 2020 available for analysis. Now, one of the key drivers and what's behind our modeled estimate of 5 to 6 million deaths that are related to the pandemic but not directly caused by the virus is levels of mobility, which are now have been well tracked by cell phone usage data. There's questions of selection bias in certain countries, but in general, we've had this very rich resource from a number of vendors about mobility as measured by people's phones moving around. And this is the global summary of that data. Massive reduction globally at the beginning of the pandemic, and then we had reduced global levels, highly variable across countries right through till May, and then since May of 2021, steadily moving back up to pre-COVID levels of mobility. The one outcome where there has been the sort of evidence has been nicely summarized is for mental health. And so Damien Santamaro and Alize Ferrari from the University of Queensland have led this collaboration, reviewing the published studies, and then making estimates for where we don't have data on the changes in major depression and anxiety. On the right, this paper came out at the beginning of October in The Lancet. And on the right, the red line is the prevalence during the pandemic of, on the top is anxiety, on the bottom row is depression by age and sex. And you can see the blue line is pre-COVID, the red line is post-COVID. There has been a considerable increment. Another way to see that results is with this population pyramid. The green and blue color is baseline depression and anxiety disorders. Green is anxiety, blue is depression. And then the increment by age and sex that is estimated due to the pandemic is in red for anxiety and purple for depression. So a very substantial estimated increment. The paper outlines many of the limitations of this analysis, so we can't be 100% sure that the magnitude is shown, but this is the best assessment that's currently available on what seems like a very substantial contribution of the pandemic to mental health disorder prevalence going up. Well, to round out this assessment of what has been the impact of COVID, given the massive global transmission, a huge increase in mortality, and least compelling evidence around mental health and likely effects of deferred care and other mechanisms to increase the death rate from a number of causes, where are we headed? And, before showing you long-range forecasts, I need to point out that forecasting far into the future is very challenging, not just because of the usual transmission dynamics and who interacts with whom. Those are always present, but we have some longer-term issues. When and whether there will be new variants that demonstrate considerable immune escape. How much is their immunity given by natural infection and vaccination wane over time? We know it does for protection for vaccination, protection against infection, but we don't yet have a lot of evidence on the waning effect of for vaccination, for protecting against hospitalization and death. The other thing that we suspect is happening is that governments and individuals will be less likely to be careful, wear a mask, avoid interaction as transmission goes up. And then we actually have issues around how much will there be uptake of boosters given vaccine hesitancy in the first go round, and how much transfer of vaccines from high resource settings to low resource settings. Bearing all that in mind, here's our long range forecasts for COVID. The green line is our reference scenario, the numbers that we think are probably most likely true. And if we don't have a new variant, and if we don't think that waning immunity from natural infection is as big an issue as some have argued, then by April or May of 2022, globally, we should see transmission coming down to quite low levels. Of course, we don't actually believe that is the case because likely variants will come along and there is going to be waning immunity. For death, similar story. We see the numbers coming down to a quite low level at the global level, dropping down to maybe 1,000 deaths a day or less by the spring or summer of next year. But again, that's without taking into account what is very likely going to be the case, which is there will be new variants that evolve and there will be waning immunity. I think personally, not backed up by a quantitative model, my view is that we will be moving towards a more seasonal model of endemic COVID that shows up each winter season, and combined with flu puts extra burden on both individuals, but also on healthcare providers as we think towards the future. Thank you very much for this quick walkthrough of what are the likely effects, have been the effects of COVID, and what they might be in the near future. Thank you.
Great. Chris, thanks very, very much for that superb overview of the health impacts, both direct and indirect. I think the mental health impacts are particularly disturbing because of the likely consequences with respect to both risk for other health problems and adherence to treatment. Your forecasts offer very fertile ground for as a point of departure for our discussion. We're going to turn now to impacts on educational systems and our children, and to Jaime Saavedra. So Amechi, could we go on to that next presentation, please?
Justice. Good morning. Many thanks to the National Academy of Medicine and to the interest group on global health, infectious disease, and microbiology for this invitation. I want to use this opportunity to share with you some insights about what has happened with education during this pandemic. This is the worst education crisis in the last century. The hit on children and youth, as we're going to see, has been tremendous. But before doing that, let me share with you a bit about where were education systems before the crisis. And in 2019, we came up, the World Bank, together with UNESCO, we came up with an indicator that we called learning poverty, which is the share of 10-year-old children that cannot read and understand a simple text. If you think, well, this indicator should be zero. This percentage should be zero. All children at that age should be able to have these fundamental skills. Unfortunately, before the pandemic, in low and middle income countries, this number was 53%. That means half of children at age 10 did not have the fundamental skills that they need for a productive life. And we're talking about all 10-year-olds. Most of them are in school. Some of them are not in school, but most of them are in school. So they are in school, but not necessarily learning. Aspiring to eliminate learning poverty is similar to our goal of ending hunger or ending extreme poverty. Those numbers should be zero. And this high learning poverty that we see, this 53%, is really an early warning that all other education outcomes that we care about are at risk. Completion of secondary education, access to tertiary education, quality education in general, all goals including in the Sustainable Development Goal 4 are in jeopardy if kids cannot read at age 10. This is really morally unacceptable. All children have the right to education, an education that provides them with the skills that they need in order to be productive citizens. But it is also economically unacceptable, because we do have the financial and the technical means in order to eliminate this learning poverty. We know how a good school works. I mean, there are resources in the country, but in countries, but it is really a political commitment that all countries need to engage in order to make sure that all kids have the right quality education. We were far from achieving that. And actually, even before the pandemic, the trends were not necessarily the right ones. Learning poverty was going down, but it was not going down at a very fast pace. But now, what was the impact of COVID-19? And when the pandemic hit, an important point is that school closures were considered part of the arsenal to fight the pandemic. And that happened without much knowledge of the benefits of keeping school closed. There was this intuition that if schools were kept open or universities were kept open, that could contribute to an acceleration of infection rates. But we didn't know much. And also it was done without much internalization of the costs borne by children and youth regarding not being at school. And actually, one thing is that we have school closures. If we had school closures of 3 or 4 months, but unfortunately, children have been out of classrooms really during extended periods. As you see in that graph, globally, the average as of now is about 155 days. But in Latin America and South Asia, if we put together complete closures and partial closures, really the numbers are above 200 days. In North America, the number is very high, but most of the closures that we see in North America have been partial, right? And so some states were open, other states were not. Some counties were open, other counties were not. But Middle East, Latin America, South Asia are 200 or more years of schooling, days of presential school days closed, and that's about 1 and even 1.5 years out of school. Now, a year and a half later, these disruptions to education still persist. As you see in that map, the countries in yellow are countries in which we will still see partial closures, and there are a few countries in orange in which the school systems are still completely closed. Oh, countries did not stand still. countries, most of them provided some sort of remote education during school closures. I mean, it was really a multi-platform endeavor. I mean, countries realized fast that they did not have access. Not all children had access to internet. In low-income countries, access at home would be 10%. In middle-income countries, 50%. In rich countries was much higher. But if we talk about low and middle-income countries, it had to be a combination between online, TV, radio, messaging apps, etc. But actually, the key point is that the experience that all different children have was extremely different. Some kids will have a broadband connection at home, books, a device, a space to read and play, while other kids, and many kids, will have nothing of that. So the experience that children have lived during this pandemic across countries and within countries have been extremely heterogeneous. Now, where are education systems now after the pandemic, or as schools were really not out of this COVID-19, but many school systems are starting to open again. And we have done some simulations to see what could happen with this 53% that I was talking before, with the length of school closures that we have had, and with the quality of remote learning and distance learnings that we have seen. And our initial simulations show that this number could be 63%. Now, recently, with the extension of school closures, I mean, particularly in South Asia and Latin America, our new simulations show that this number could be even close to 70%. Now, academic learning is only just one aspect. We see many other issues that are impacting young adults and children. We have 24 million additional students which might drop out of the school system. 370 million children have missed a daily school meal because their main meal was at school. 13 million girls, more girls, might marry early, particularly in Africa and South Asia. There is a doubling in the rates of depression and anxiety symptoms in children globally. With the losses in learning and with potential school dropouts, we estimate that this generation might be losing about $16 trillion of future income. And I'm not talking about the losses for economies in general, but losses for this generation in terms of future income and future well-being. This $16 trillion approximates about 12% of global GDP, just for you to understand that this is really a large number. And the other issue that worries us a lot is that there is an inequality catastrophe ahead of us if we don't do something. And an inequality catastrophe across generations, by socioeconomic level and by education level. I'm going to give an example of each one. In terms of what might be happening to this generation, we have some learning data post the school closures. I mean, not a simulation, but this is real data that starts showing that this generation is experiencing large learning losses. And this is with this real data, we see, for instance, that the actual data that in Karnataka in India, only 16% of grade 3 students could perform a simple subtraction in 2020, but that was compared to nearly 24% in 2018. In South Africa, grade 2 students have learning losses that are up to 70% of a year of learning. In Latin America, in Sao Paulo, Brazil, stated that measured learning continuously throughout the pandemic. At the end of 2020, students have learned only 28% of what they would have learned if they have had presential classes. We need to have more data on this, but actually we even see some reluctance of many countries of measuring learning, because actually news are going to be bad. But as I'm going to say later, we really need to have that data, even if they are bad news. But learning losses are unequally distributed by socioeconomic level. As I said, the experience with distance learning has been very different, right, across different students, from poor students really having no exposure to rich students having, some decent, online experience. We don't have data yet for poor countries or middle-income countries, but for rich countries, let me give you the example of United Kingdom, 50% higher losses in reading in schools serving disadvantaged students. In the state of Maryland in the US, we see that comparing 2021 with 2019, overall reading readiness fell by 35 points. But if we look at disadvantaged students, that number went down by 46 percentage points. And in addition to these hits across generation, across the income scale, the experience has not been the same for students in different grades. And actually, it is much worse for the younger kids. And here we have data again for the state of Sao Paulo in Brazil. And we see that the change in scores in grade 5 comparing 2021 and 2019 is 29 points. In grade 12, it was only 11 points. And this is something that we see in the US clearly as well, and much larger losses in the early grades. Now, let me start finishing and wrapping up with some lessons from the pandemic. One first lesson is that we need to close the digital divide. I mean, the school systems are going to be more resilient, right? If education can continue at home, all kids need to have device either for presential education or for remote learning, and the use of technology can make teachers much more impactful. But at the same time that we need to close it with digital divide, another lesson is that education is really a social phenomenon. Education is about the interaction between the teacher and the student, interaction between the student and her peers. Education, that magic of learning happens, right? When in presential education, universities, schools, they are all the social space. And at the same time, we have learned that teachers are really critical, the fundamental aspect of the education process, as those people who coach, who facilitate, who inspire the children in their learning process. So we put these two issues together, actually a key lesson for the future, a future that really has been propelled to today is the need of a balance between technology and the human factor. But the other important lesson is that there has to be an understanding of the critical role that parents play in the education of their children. That's very clear for some parents, but it's not that clear for many. And actually, it has to be part of public policy to make sure that there is support for parents to really be able to help effectively their children. And at the same time, we really need to work to strengthen the home environment. There are some homes in which there's a computer, there's internet connection, and there are books, right? And other homes lack that. And actually, that has to be part of public policy. We do some countries in which they worry about making sure that all children have books at home, right? And actually, that has to be an integral part of public policy, something that we actually do not see yet in many poor and middle-income countries. And actually, this is what would contribute to resilience, right? To assure that there are the conditions to make sure that there is a continuity of the learning process from the school to home. And in addition to these lessons that are about shaping our education systems for the future, we really need to have urgent action today, right? To accelerate the learning recovery. I mean, this year and a half in which millions and millions of kids have been out of school can generate a huge hit on this generation, and we cannot afford a permanent impact on this generation. But so that means that we cannot just try to go back to school as if nothing has happened. Really, this requires a critical effort of all countries. First of all, is to bring all children and youth back to school. And this is really not trivial. This will require very intensive communication campaigns so that we make sure that particularly secondary education kids come back to school, and that we also do not lose many kids or many young people in tertiary education. Second, we need to really measure learning, even if that's bad news. All countries need to know where they are, what has been the magnitude of the shock, either for the country as a whole, and also in each district, in each province. Third, countries, and in each school, in each classroom, we need to prioritize the fundamental skills of reading and numeracy, and we need to prioritize psychosocial well-being of children. Third, we really need gigantic efforts, right, to provide effective remedial learning, help kids to catch up where they are, make sure that children are taught at the level they need. It's not a matter of using the textbook of this year. You are receiving fourth graders that might have at this moment the skills of early third grade or at the end of second grade. So we need to make sure that we start with them, teaching them at the level that they are today, so they can accelerate their learning. And finally, all this requires a very, very aggressive support to teachers, to helping them to address these learning losses and helping them incorporate in digital technology. Many of these actions are something that has been incorporated in what we call Mission Recovery Education 2021, which is an initiative with UNESCO, UNICEF, and the World Bank, which is basically about helping governments, helping countries, right, in order to tackle all this, or implement all these policies to tackle the huge urgencies that we have. I just want to close saying that we really need to have a sense of urgency, right? This really needs to be implemented today, because we really cannot afford to lose this generation. Thank you very much.
Well, Jaime, thank you so much for that terrific and frankly somewhat chilling summary. I think the impacts on our children that you describe are deeply disturbing, particularly because they're potentially so far-reaching. I'm sure we're going to return to your framework for urgent action on recovery during the discussion. We'll move now to the impact on the global economy and to Stephanie Siegel's presentation with Amichi's help.
Hi, I'm Stephanie Siegel, and I'm a senior fellow with the economics program at the Center for Strategic and International Studies. I'm going to present on the issue of fiscal space and creating fiscal space in an era of COVID-19. Let me go ahead and share my screen. All right. So this presentation is going to be based on work that I've done along with Steve Morrison, who directs the Global Health Program at the center, and also work of the CSIS Commission on strengthening America's health security. The Commission has actually worked to introduce fiscal policy into the discussion on health security, kind of appreciating that health and resources to finance health spending are very much connected. And if we can say anything positive about COVID-19, it's been that it has forced an appreciation of health as an economic issue. I suspect to this audience, that's not new news, but it is true that COVID-19 has really underscored the links between public health and economic outcomes. And when I've been asked to speak about the economic outlook coming out of the crisis, I always make the point that COVID-19 is a health crisis that's led to an economic crisis. And therefore, the durable solution to the economic crisis goes back to health. Part of what we've been underscoring in our conversations has been the very different country capacities to respond to this crisis, but also different country capacities to respond and actually invest in public health and pandemic preparedness. And we've seen that loud and clear, or heard that loud and clear in the current crisis. Because of those very different capacities to respond, we actually have a risk of greater economic divergence between countries, but that also presents an opportunity to invest in public health and pandemic preparedness, and actually kind of use this moment and this heightened appreciation of the linkages between public health and economic outcomes to ensure greater international investment. So on this point of different country capacities to respond, This chart looks at fiscal policy response by country type. It looks at fiscal policy response by advanced economies on the left, and I've shown the US here as well, and then looking at emerging markets, EM, and then low-income developing countries, which is on the far right. So we're looking here at discretionary fiscal responses to COVID-19. This is data that comes from the International Monetary Fund, and they look at both additional spending and foregone revenue, so things like tax relief, as well as financial supports that could have a fiscal cost. So think of things like loan guarantees. So on average for advanced economies, you see a fiscal response in the range of 25 to 30% of GDP for advanced economies. That's a huge amount. The United States is right there kind of in that average, but much more of the response has gone through additional spending or tax relief versus Europe that has had a greater reliance on guarantees, but the amount of support, that 25, 30% of GDP is right where the US is as well. And if we look then at emerging markets, that number, the combined supports between the two, is around 7% of GDP. For low-income developing countries, it's around 2% of GDP. So you see clearly the very different capacities to respond to the crisis coming through in the numbers. And we see that divergent response also reflected, as you'll know, in vaccination rates. Again, looking at IMF data, and this is interesting, I talked about the opportunity to really link the health discussion and the economic discussion. I think we have one sign of that in the collaboration between the IMF and the World Health Organization. But they have their vaccine supply tracker. So this is not administered vaccines, but secured vaccines. The actual country names are too small for you to read, but the point here being that it's the advanced economies, the high income economies that have secured multiples of their population in vaccine. The line in black there is the United States. And then, as you would expect, as you go down the income scale, you move closer to the right. At the lowest end of the scale, those are all low-income countries that have secured at the lowest ends less than 50% of their population. So again, not delivered vaccines, but just secured vaccines. So you see this uneven fiscal response, you see uneven vaccine supply. And then if we look at vaccines actually delivered and administered, as you would expect, you see the same kind of disparity. So on the left-hand side, we look at the global average, and this is data as of midsummer. So these numbers have improved since then. But you see this big divergence between advanced economies, emerging market economies, and low-income economies, where advanced economies administered vaccines are around 35%, in emerging markets around 10%, in low-income countries below 2%. And if you kind of link the vaccines to the ability to reopen the economy and get back to regular economic activity, you would not be surprised to see the correlation between vaccines and declines in the employment rate, where you have the greater employment losses coming from emerging market and developing economies. And even within those countries, some of the more vulnerable groups, the low-skilled workers and women, employment losses actually being greater still. So what does that then mean on a macro level? And here we look at a two-speed recovery. These graphs show what the pre-pandemic growth and GDP was expected to be. So that is the black line. So had the pandemic never hit, what was the growth path for advanced economies, emerging market economies, and low-income developing countries? And then you compare that with the current projection, that's the blue line. The good news here is that in advanced economies, by the end of next year, should be caught up to their pre-pandemic growth trajectory. So we will have recovered and then some in many country cases, including the United States, actually be above the pre-pandemic growth trajectory. That's for advanced economies. In emerging market and low-income countries, you see that gap between the black line and the blue line, where even by the end of next year, they will be below where they would have been had there not been the pandemic. And the fund is forecasting by the end of 2023 is when you'd actually have the catch up to their pre-pandemic growth trajectory. But obviously there's a long way between here and there and actually the achievement of that catch up. But the fact that there's a two-speed recovery is really not a debate. We see it clearly in the numbers. So this widening divergence, we know already last year we had the World Bank reporting that they observed an increase in global extreme poverty for the first time in over 20 years. We also know that there is slower vaccine rollout and less policy support in low and middle income countries. And then we know that lower economic activity leads to human capital losses, both education, but also in employment and employment training. We know that there's a large debt overhang in many of these countries, and to the extent that debt is both a stock question, but also the ability to service that debt is a question of economic activity and revenues that are collected. The longer that economies are hobbled, the worse those debt dynamics become. And that can then lead to persistent output losses. So it's not just a question of getting past this immediate crisis, it's actually, are there going to be sustained and enduring impacts of the crisis that actually lower potential growth beyond this current crisis? On the debt point, let me just show you a graph that kind of makes the point of the worsening debt burdens. And this, unfortunately, is not limited to low and middle income countries, but also an advanced economy phenomenon as well. We look here at national debt as a percent of GDP, and we see that across all country groupings, we've had a pretty dramatic increase in national debt, stemming from the response to the global financial crisis in 2008 and 2009, and now in response to COVID-19. Advanced economies haven't actually faced a financing constraint. We still can borrow at very low interest rates. So we have not been constrained by this higher debt burden, at least not yet. But we see in many low-income countries, and if you look in particular at Latin America and at Africa, the color changes going from 2007 to 2020, you have these large increases in debt as a percent of GDP. And in low-income country cases, some of that debt now being considered unsustainable, so they're not actually even able to access financing. So obviously that constrains not only their ability to service that debt, but to then meet other financing needs, and specifically financing needs for public health and for overall economic support. So there is a need to create fiscal space in many of these countries. The question is how. So there have been efforts already in the current crisis to create some of this fiscal space. The most well-known, I think, is the Debt Service Suspension Initiative, which suspends debt service for a particular defined period of time for low-income countries. And the condition being that any debt service that is not paid be redirected to social, health, or other economic spending. And in exchange for that, countries will increase transparency, disclose all public sector financial commitments, and also limit further non-concessional borrowing. So there's some relief there, but that relief is time-bound, as I mentioned. So there may be the need, and there is the need in many countries, to actually have more sustained debt write-downs, debt treatment, and the mechanisms for doing that are still, I would say, under development. There's a common framework that's intended to pull a larger group of official creditors into this restructuring process. There are a few countries that have made use of the common framework and are working on getting that sort of treatment, but it's too early, far too early to say that that's been successful. We're kind of waiting to see. But really, there's the need for additional donor support in response to this crisis, and additional donor support being grant support, that many of these countries can't actually take on additional debt. So they need grant financing from wealthier countries. And that shouldn't come without some strings attached, in the sense of the goal here should not be to create kind of ongoing dependence on donor financing, quite the opposite, that domestic reforms that boost public financial management, transparency of public finances, and actually boost domestic revenue mobilization so that countries can actually finance their own public health spending needs, that actually needs to be part of assistance that's provided to countries. So the assistance is provided in support of domestic reforms that are needed for sustainable solutions for public health. So if you can create that fiscal space, then how do you use the fiscal space that you've created? I'm not going to be able to improve upon recommendations that came from the high-level independent panel. It's a group of experts that reported to the G20. They articulated pandemic security along with the climate crisis as representing the primary international challenge of our time. They identify 4 major gaps in pandemic prevention, preparedness, and response that include globally networked surveillance and research, more resilient national public health systems, the supply of medical countermeasures and tools, and of course, global governance. So I'll end there on that note of global governance. I'm sure everyone is familiar with the expression of the pandemic isn't over anywhere until it's over everywhere, and that certainly requires a global response. So thanks so much for your time. I'm really looking forward to the discussion after today's presentations. Thanks so much.
Great, Stephanie, thank you so much for that great overview. The G20 high-level independent panel recommendations certainly give us an excellent springboard for our discussion. And now we're going to go to our final presentation on what history tells us about how epidemics end. And I'm going to turn this over to Erica Charters with the Mechi's help. Thanks.
Thank you very much. It's an honor to be speaking to you. So this talk is part of a broader project which examines the large question of how epidemics end, which I'm coordinating out of the University of Oxford. And so across the past 12 months, I've been working with around 40 scholars who research a variety of epidemics that have happened all over the world, but who look at them from different disciplinary approaches. So epidemiologists, biologists, archaeologists, historians, political scientists, all to answer this question, how do epidemics end? And so what I'm going to present today draws on this preliminary research, but I hope that you will visit the project's webpage as we're going to be releasing their case studies across the next few months. In what follows, I have 3 points I want to make. The first point is that when we compare how much time and attention we pay to studying the origin and the unfolding of epidemics, it's clear that by contrast, we spend far less time studying the ending of an epidemic. The second point is that when we do focus on endings, it's clear that an epidemic's end is not the same as the end of disease, and that there are multiple endings to every epidemic, not only across the world, but even within one society. And so as a result, when we focus on endings, this lets us see that epidemics are not only biological phenomena, but there are also political, cultural, and social phenomena. My final point is that when we focus on the end part of an epidemic, this reshapes how we think about the history of pandemics. It helps us to move away from a serial narrative of one after another. And it also helps to suggest that we require a more integrated view, both of epidemics and of the relationship between epidemics and society. So first, on endings. I think once you start researching the ending of epidemics, it's striking how little attention is paid to the process of an ending. And an example of this can be found in what is really the seminal account of an epidemic for Western literature and history, which is Thucydides' account of the plague of Athens in 430 BCE. And although much has been written and debated about what disease Thucydides is describing, what's clear is that Thucydides' account is a foundational epidemic narrative. That is, historians have pointed out that later accounts have an eerie habit of repeating Thucydides' account. So it appears to shape not only the way that we tell ourselves stories and histories of epidemics, but also it shapes what we look for and what we think is important enough to be recorded as an epidemic unfolds. So it's significant to understand how Thucydides recounts the end of this devastating plague. And after he describes the symptoms, the deaths, the social dislocation, the economic devastation, the political and religious upheavals, the disease simply disappears from his text. So it's mentioned as all-encompassing, but then it's gone. And I want to underline this. Thucydides is not tracking a decline in cases, nor even the process of returning to normality. Instead, the disease simply disappears from his narrative. Disease has exited the stage without further comment, and other actors silently take its place. So in other words, we, the readers, know that the epidemic is over because it's no longer part of the plot. Now, in many ways, this silence is fundamental to the very definition of an end of an epidemic. After all, an epidemic is a crisis, not only a biological one, but also a social and political crisis, during which time society's attention is focused on this urgent problem of disease and the drama of its unfolding. The end of an epidemic is therefore when the drama ceases, when society's attention is no longer focused on the crisis of disease. Now, when we examine research and scholarship on epidemics, there's a similar tendency to neglect this end stage. So there's a lot of research on origins, on tracing and tracking transmission patterns, and on the climax of an epidemic, but there's little analysis on what it means for an epidemic to end. Most often, we see how the ending is relegated to a brief conclusion, or maybe even an afterword, usually titled Lessons Learned. And so with attention already pivoting away from the end itself. As we can see with Thucydides, in some ways, this is the result of the evidence itself, right? The very definition of the end of an epidemic is when our attention is redirected elsewhere. It's an indication that this urgent problem of disease has been resolved, and when we stop keeping records of the epidemic. But we see this pattern in fields beyond history. So in mathematical modeling, as a recent epidemiological modeling paper points out, many works have focused on the growth peak and controlled phases of epidemics, but much less studied are the tail end dynamics of an epidemic. So I think it's interesting to note how, in some ways, the statistical charts of cases, the epidemic or the epi curve that's so ubiquitous in our visualizations of an epidemic's life cycle, provides the same underlying temporal framework that we see in, say, Thucydides' account of a narrative of origin, climax, and then a kind of drift to closure. This, of course, can help us to define how epidemics end. An epidemic, of course, is clinically defined as an increase, often sudden, in the number of cases of a disease above what is normally expected. This, of course, warrants official attention, if not designation as, in the terminology of the WHO, a public health emergency of international concern. By contrast, when the crisis recedes, the disease is no longer cause for alarm, a society's attention can be redirected elsewhere. So to my second point, when we do focus on an ending, what do we find? And here, a main point to remember is that we need to disentangle the end of disease from the end of an epidemic. A few select epidemics, such as SARS, have indeed been declared over when cases among humans ceased, but most epidemics have not concluded with the end of disease. Instead, most epidemics have been declared as ended while cases still continue. If we look at the 2009 H1N1 swine flu pandemic, for example, it was declared by the WHO in August of 2010 to be in what they called a post-pandemic period. And the WHO noted that this post-pandemic period would have cases and outbreaks according to seasonal patterns of influenza. And this actually follows long-standing historical practices of distinguishing between an end of disease and the end of an epidemic. So medieval Arab medical texts, for example, distinguish between widespread or epidemic outbreaks and individual cases of disease. Likewise, in England, at the end of its many 19th century cholera epidemics, these were most often declared through days of Thanksgiving, but it was clear in the language the disease had not ended. So you can see here the language of these days of Thanksgiving, right? In 1849, we talk about the great decrease or the abatement of cholera. What this means is that the end of an epidemic is a process, and often even a long, drawn-out, contested process. As an example of this process and the way language is used, we can look at the end of the devastating Ebola virus epidemic in West Africa that was officially declared over in 2016. But prior to this ending in 2016, Ebola was twice declared over in 2015, only to have more cases observed. So in other words, there were 3 end declarations by the WHO. And not surprisingly, the language shifted in each end declaration. The first declaration in May 2015 said that Liberia was Ebola-free. The second one in September 2015 was more soberly reporting an end to Ebola transmission. Then after it was identified again, finally in January of 2016, much more cautiously, the WHO announced the latest Ebola outbreak was over. And of course, as recent research increasingly indicates, it appears that Ebola will continue to reappear. This means, of course, that epidemics, and particularly their endings, can only be understood within a broader context of continuing disease. Influenza A, with its various strains in circulation throughout the world, is a classic example of a disease that rises to epidemic, that is problematic levels, and then returns to endemic or acceptable levels in unpredictable waves ever since it first appeared among human populations in the 1500s. And given that an epidemic is defined as an increase in incidence beyond usual rates, the end too can be clinically defined as the reduction of disease incidence, prevalence, morbidity, or mortality to a locally acceptable level to achieve what is widely described as disease control. Yet, as ambiguous terminology such as acceptable and control demonstrates, this status is necessarily achieved through a process of negotiation between different, if not competing, interests, particularly as historical examples demonstrate that an epidemic's end can be gauged by the resumption of social and economic practices as much as through biometrics. And I would suggest this very process of an end highlights these competing approaches. Discussions on the ending of HIV AIDS, for example, these are debates as to whether it's more effective to invest in vaccine research, in medical therapeutics such as antiretroviral therapy, or to invest in social and political reforms. And these all articulate different methodological understandings of the epidemic. Such divergent approaches, of course, also reflect different global circumstances. What might be feasible in communities with sophisticated health structures cannot be replicated in those confronting limited and unstable medical support, if not also political fractures. So what is deemed a locally acceptable level is thus necessarily a process of social and political debate as much as it is about medicine. More generally, what I want to suggest here is that a focus on ending helps us rethink how we study epidemics and disease more broadly. The end process is not simply the downward curve of an epidemic. Instead, it marks a different way of thinking about the epidemic. That is, a society's understanding of an epidemic is different at the beginning and the climax than it is at the end. When communities are thrown into turmoil and panic, at the outbreak of a new disease, when medical committees are convened, when central governments spring into action, when we hunt for the identification of a pathogen, epidemics are understood in clear biological terms. But at the end stages of an epidemic, the disease is regarded through the filter of political, social, and economic dislocation, and these dislocations that have deepened as the epidemic has progressed, articulating the processes by which policy decisions are debated and implemented, and the accommodations that have been made between scientific models and human behavior. Now, what I'm saying here is not just a reminder that the crisis of an epidemic, the political and the social and the economic crises, do not end just because disease rates slow down. Scholars have noted, for example, that most pandemics have ended at different times and in different places. HIV AIDS, for example, may have ended for most in the global north, but in some ways it simply moved and continued on as an epidemic for many in the global south. The second plague pandemic, too, receded from Europe, while most of the world did not witness anything such as an end. Now, this framework for disease and epidemics contrasts markedly with how we generally understand epidemics. When we look at this image here, which is from the website The Visual Capitalist, which provides data graphics as part of its mission to make the world's information more accessible, you likely maybe haven't seen this particular image, but I'm sure you've seen a version of it, maybe even in written form, of following this format of listing disease outbreaks, pandemics throughout the past. This one here starts with the Antonine Plague in the Roman Empire through to the Black Death, smallpox, cholera, placing all these major pandemics in chronological order, that spiky red ball at the front representing COVID-19, and all captured by numbers of death. And although it might be unnerving in some ways to look back and see these large numbers who've died from past pandemics, overall, this image of the history of pandemics is generally reassuring when we are positioned at its front. After all, COVID-19 appears at the end of a long list of biological calamities. Each of them have been solved, so it's presented as a kind of yet another test of human and scientific ingenuity. Each pandemic here is shown as circumscribed and defined with clear contours of their respective ends. Yet, if we were to incorporate in our understanding of the ending as a process, we can start to challenge this framework. Plague, for example, was not a discrete disease entity with a clear start and end. It would be much more realistic to portray the second plague pandemic something like this long wavy line, thicker in some points than others, weaving back and forth, but ever present, only occasionally rising and exploding above the surface, much more akin to an iceberg in which we only see the tip above water with the mass of disease hidden below. If we look more generally here, we'll notice that endemic disease appears not at all, right? Tuberculosis, which would help to explain the pattern of HIV AIDS, certainly is not featured. In other words, in this framework, there's no space for interaction between diseases that is so often crucial to understanding the fluctuations of epidemics. Instead, the focus is on epidemics as isolated, discrete events that decisively end throughout time. By contrast, if we incorporate endings and on the process of an end, our history of pandemics, I would suggest, would look more akin to this visualization here of a sound wave, with epidemics and society portrayed as a process of co-evolution. In this framework, diseases interact with one another, but they also interact with societies. Neither is static, and the development of disease and society only makes sense when we model their dynamism together. Long before COVID-19's entanglements with comorbidities, researchers have pointed out that disease fundamentally interacts with other diseases, and epidemics too are fundamentally shaped by concurrent and previous patterns of disease, along with societal frameworks and practices connected to memories and to fears of disease. Now, this observation is not only historical. After all, we use the past to identify patterns and thereby outline trajectories for the future. By focusing on endings, when the definition and the categorization of an epidemic becomes murky and contested, we can start to see that the categories and periodizations that we used at the outbreak stage were perhaps counterproductive. We understand disease differently at the end stage. If in the outbreak stage we could channel that end stage understanding of disease, it might help us reframe and rethink our long-term approach to managing disease. Thank you very much.
Erica, thank you for that very important perspective on epidemics and their interactions and co-evolution with societies, as well as with other diseases. In fact, I think it's pretty clear that as we move to the end of epidemics, disease predictably moves into or concentrates in the most marginalized populations, which of course means we have to change our approaches. Your call to reframe and rethink our approaches is actually a perfect segue into our discussion. So I'm going to turn this over to you, Patty.
Hello, and thank you so much, Judy. Thank you so much to all the presenters. It has been a really exciting session, thinking about all the different aspects of COVID and what can we see in the way forward. I just want to remind all the NAM members, if they have any questions or comments, just put it into the chat box. And if you would like to ask a question or make a comment verbally, please type it, the basic question, and put unmute. And the team will unmute you and we can have the discussion. Also for the public registrants that are viewing this session, unfortunately, there is no way to send us directly your questions. However, we're very interested on knowing about them, and we would like to hear from you. So please send those questions through email. And the email is namig02@nas.edu. And all the questions and comments will be collected after the meeting and will be sent to the appropriate panelist. And the response will be sent to you accordingly. So let's start then with some of the questions that we already have collected regarding the presentations. And I would like to start with Chris. Chris, you have talked about transmission, you have talked about deaths. How much does the infection detection rate vary during the pandemic and across countries?
Thanks, Patty. I think because most people focus naturally on reported cases, and only a fraction of actual infections get detected, and that's a function of availability of testing. And that availability of testing was very low at the beginning of the pandemic, increased in high resource settings, but has stayed low in many countries. So I think people get a little bit misled by the reported cases because the infection detection rates, as high as 40 or 50% in some high resource settings, whereas it's well below 1% in many countries in sub-Saharan Africa, many countries in South Asia. And we only know that because there have been population-based seroprevalence surveys that tell us about cumulative infections, and then you can relate that to reported infections. And unfortunately, one of the big question marks about the pandemic so far is just what has been the true level of transmission in many parts of sub-Saharan Africa, outside of, for example, South Africa, Zambia, a few other places. And it's the dearth of, hard data on seroprevalence to tell us what's actually happened and what the infection detection rate is.
Thank you so much, Chris. Jaime, you have talked about the need of accelerate learning. What else has to be done to be able to achieve that acceleration in learning? And how can we create more resilient schools for the future pandemics?
Thanks, Patty, for the question. Actually, this is extremely challenging. These are extremely challenging times for school systems, and for schools and for teachers, because they will be receiving students, or they are receiving students that have that are undergoing much more complicated situations at home, mental health issues as we have seen, and actually an extremely long interruption of their studies. So the big question for countries is where to start, because you cannot just open the textbook and say, okay, let's start in the grade in which you technically, formally you are now, right? These kids might have left school that's whatever, 3rd grade. Now they will be enrolled in 5th grade. And but actually they don't have the basics or to build learning, and learning always builds over previous learning. So actually school systems will have to find a way to make sure that this generation have, at the end of the day, the same competencies, at least the same competencies in the previous generation to the next generation. So hence that implies compressing 2 years in 3 years in 2, or 2 years in 1, right? Or try to use all what remains of the school time of children in order to make sure that they acquire the same competences that they would have acquired without this very, very long interruption. So actually that's the key factor, how to do that, right? And that requires streamlining of curriculums, prioritization, changes in school calendars, changes in methods, right? And that requires that we need to provide huge support to teachers, right? That was true before the pandemic. Now that is even more urgent. And the one additional point I want to make, Patricia, is that sometimes the school systems have forgotten early childhood education. In the literature was already established that the investments in early childhood education, in pre-K, say, let's limit just for the enrollment of kids to formal institutions in ages 4, 5, 6. That has the highest social and private return, much higher as a social as a public intervention, higher than primary, and primary is higher than secondary, etc. That investment that is the most profitable disappeared completely. That one went literally to 0 across all countries. Right, so those and recovering the lack of experience that you had during your year 4 or 5 or 6 is extremely difficult. Right, so and again, right, then the teacher in 1st grade, now that has to work with a child that has very, very little exposure to the education system, right, and it has a completely different way of interacting, and his or her socialization process has been completely different. Right? So again, the support that is needed to teachers is absolutely urgent. And that's something that school systems have to be doing as we speak. This is not the plan for next year. This is the plan literally for today.
Thank you, Jaime. Stephanie, in your presentation, you were talking about additional donor support is needed to create fiscal space. Are there any proposals out there regarding this issue, and what are their prospects for gaining traction in the United States and among other larger countries? What are the options?
Yeah, thanks, Patty, for the question. I think there are a lot of proposals that are out there currently. I mentioned in the presentation, the high-level independent panel. The WHO has its own independent panel. I would say the good news is there is agreement on the need to mobilize additional financing. And there's also agreement among the wealthier countries, including in the United States, to prioritize mobilizing additional financing. So that's the good news. I think there's political will behind that additional support. I think the question then is which mechanisms, and there is a competition for resources. And I would say there's also perhaps kind of skepticism about how different pools of resources can actually be used in a way that is complementary, so that the benefit from those additional resources are actually working together and being coordinated. So that is a challenge that I think needs to be answered in order to actually match commitments to actual delivery of funding. And one last thing I would say on that point, it actually relates to some questions that I've received just in the chat, is the point about, to the extent there's support to mobilize resources, that there is funding available how to actually ensure that those resources are used in a way that benefits the countries and benefits populations. And that's the link that I mentioned that ties additional financial support to domestic reforms. I think it's really critical to view those two as kind of reinforcing mechanisms. So additional revenues, but in support of better public financial management and prioritization of the spending. I think if you can demonstrate the linkage of the funding to those domestic reforms, you really maximize the chance and the prospects for mobilizing that financing.
Thank you so much. And Erica, in your presentation, of course, this is a question that everybody asks, okay? What can we learn from history, okay? If you want to give the message, okay? And how can we learn it, okay? Because it seems that things have been happening all along. And what can we learn from history for the future of the pandemics that are to come?
So in some ways, I'm in the luxurious position of saying that historians generally try to say that we're not sure that we can agree on what we can learn from history. That actually, I think historians have a tendency to say that our own urge to think that there's a lesson coming out of everything that's a tragedy or terrible might say something more about us than it does about the experience itself. And to me, actually, this urge that we have to see this as something where we're going to learn something might be an opportunity for us to reflect on our own framing of an epidemic. I think as a historian of disease, what we tend to emphasize is how epidemics are not, and disease is not something that's external to society. An epidemic isn't something that comes down from outer space like an alien and acts on us. It's actually part of society. And so we need to understand how our own interpretation and our kind of urge to have a moral framework comes from our own urge to make sense of what has been a crisis. So I think I would in some ways almost want us to challenge our need for a lesson, and partly because I think the other point that we can make when we think about disease as being part of society is that epidemics tend to exacerbate pre-existing tensions and crises, right? They don't necessarily create anything anew. And I think that's something where we can think about the language that we use. Very often we can see from a long-term perspective that what an epidemic is doing is reinforcing certain attitudes, reinforcing certain views, and sometimes reinforcing certain tensions, as well as further exacerbating some of the problems that we've already identified within our society.
Thank you so much. And I really love the figure that you show in which you were mixing not only one disease, but other diseases plus other things that happen with humanity. So we're starting to have more questions, and I'm going to give this question to anybody from the panel that would like to answer it, okay? What role does civic society, resilience, and innovations play in addressing different aspects of the pandemic? This can be local philanthropy organizations, food banks, informal primary education initiatives. What is the role that civic society have? I don't know if from the point of view of history, economics, or education, anybody that would like to try and answer.
I can offer a non-expert thought on this, and maybe it kind of links to what Erica was just mentioning and what we can learn kind of on the history of this. But I feel like one of the takeaways from this experience is considering ex ante a country's system and kind of reliance on national or state level mechanisms versus what actually exists at the local level. And there are going to be others on the panel that are kind of better positioned to think about this, but there needs to be a tailoring of the policy response that fits with the reality of each individual country. So the question, I think, is a good one. There are going to be certain country circumstances where civil society and local actors are actually the right place to direct assistance, versus in other country contexts where there's a federal approach or a national approach that's adequate to or best positioned to handle the response. But I think maybe the the short answer is that responses need to be tailored to reflect the realities of each individual country.
Thank you, Stephanie. Jaime, do you want to say something?
Yes, I mean, and also using something that, to answer your question, but using something that Erica mentioned, that the pandemic reinforced certain views. So we have always said that parents and communities are important, right, in the education process. That has always been said, but I mean, now this takes it's been taken to another level, right? That if we want to have resilient systems, we need to recognize the continuity education process from school to home or from school to community. So hence the role of communities in terms of organizing themselves, and the role of parents in being really protagonists of the education of their children. Now it has been reinforced, and now is even clearer. Now, reinforcing that role and having communities really worried about education of their children, I think this is a window of opportunity. Will that window of opportunity be used? We don't know, right? And it's not clear to me that it's been used. I do not see across countries the same sense of urgency, for instance, about the understanding of the gigantic hit, the gigantic shock that this has implied on our kids and our young people, right? That's why you see countries in which the return to school has been extremely fast. Many of the OECD countries, they have tried to return after 3 or 4 months, right? Saying, no, this is urgent, we need to go back. Education is a social process. Kids need to go back to school, right? While in other countries, unfortunately, many middle-income countries or low middle-income countries, it's like, well, it's better to have kids at home, right? The pandemic is too complicated. Well, they will return eventually, right? Now they're starting to return, right? But the sense of urgency is completely different, right? But then that's the role of civil society, right? In terms of pushing governments, right? And say, look, no, education is critical on one hand, right? Education is a social activity, so schools are needed, right? Their role is absolutely essential. And as of now, it's been very different across countries.
Thank you, Jaime. So maybe this question goes to Chris, okay? Are there any measures of misinformation on pandemic outcomes? Things like resistance to mask or vaccination based on political views or other beliefs?
That's a really interesting one, Patty. I mean, if you think about it, there's various groups that have been trying to look at this. I tend to think that we need to go back and look at all the mistakes that the public health community, institutions like CDC made, WHO along the way, being opposed to masks at the beginning, telling people who were vaccinated when the Delta variant was about to arrive that they should stop wearing masks. There's been, it's not technically misinformation, but there have been misinterpretations of the data or as many challenges on that front as, all the information that's out there on the internet around vaccine efficacy and side effects of vaccines, or, the benefits of therapies that have no benefits and have harms. I don't know of any specific metrics around this. I know that groups like Facebook have been trying to think about that, but I don't know of any exact metrics to track misinformation.
Thanks. Myron, you have a question?
I have 2 questions, but let me ask Chris a question first, because he was just talking. So Chris, in your wonderful comments, you pointed out that one of the speakers pointed out, like the reduction in influenza is a palpable, quote, not benefit, but side effect. But I think most of us believe that side effect is related to masks. That we've kind of shown that influenza can be controlled better by a masked species than by the vaccines we've used. So I'm just curious how you weigh that into IHME, that the flu benefit. I'm sorry to put you on the spot.
No. I mean, we're as you know, we've been mask champions from early in the pandemic. And, we've seen this huge reduction in flu in, as you say, we think it's from mask use. And as we look ahead with mask use in most of the world going down, we got down to about 20% in the US in the summer, went back up when people got scared by Delta, but only to about 40%. Now starting to head back down. So we expect flu to come back. So that benefit was short-lived. I think, and of course, we try to factor that in, and we're also trying to, because of demand from health system managers about what will be the double burden of COVID and flu in the winter, we're very much interested, is it possible to do a better job of modeling the demand on hospitals from both. So that's on something that we're trying to address. But I do think the real question that you've raised, Myron, is can we change culture towards seasonal mask use in the future for those who are at risk, those who are over a certain age or have certain comorbidities, because there are very clear, obvious benefits of seasonal mask use. And I think that would be, we could save an awful lot of lives in the long run.
So flu is more fragile than flu transmission is more fragile than we thought it was. That's kind of one interpretation. COVID transmission is more robust, but that's a statement, not a question. Let me ask Jaime a question really, really quickly after his wonderful comments. So the thing that, there's no way to leave there with not chilled, just as Judy said. That's the response. But getting children out of the household and back to school, you've emphasized that in a very compelling way. However, especially in the more advanced societies, there's this concern that children will be vectors of continued pandemic spread. How do we ever weigh the cost and the benefit? And vaccines for children are going to be a very, very debatable. That's going to be a robust discussion about what are we going to vaccinate children. I'm just curious how, from the World Bank point of view, you weigh this, because I'm 100% sure you want the pandemic to go away. So if you could comment, that'd be great.
And before you say that, Jaime, and adding a little bit to Myron, because I have been here in Peru, and one of the concerns is, in the middle of all the cases, knowing that you have an overwhelmed health system, and that the fact that children will start going to school means that you need transportation and other services, which means like everybody will be in the streets. How do you really manage this risk versus benefit in the middle of the peak or in the crisis, right? Especially when the one crisis came after the other one wave after the other one.
So look, no, thanks, Myron and Patricia. It's very different today than it was, I don't know, July or August of last year, right? When we were really navigating an ocean of ignorance, right? And we really didn't know exactly what was the role that opening school systems would have in terms of spreading more the virus. But as of now, we do have evidence of many school systems that have opened, in which it's clearly that have opened even before the availability of vaccines for teachers, for adults. And actually, there has been no change in the path of the pandemic because of the school systems being open, right? That was a valid question. Well, now we have the data and we have the evidence. That didn't happen, right? Now it's the U.S. school system is opening now, right now in September and October. Right, and as the school system is opening, right, the virus is, right, the pandemic is, at least for now, is decreasing in this intensity. But that's just one example. We have many other examples of even European countries who opened their school systems between the second and third wave, say, in the fall of last year, and that didn't have an impact on the pandemic. And actually, the data shows today that the transmission rates among children is low, even despite Delta, and also that the death rates among children are very low, right? So the point is that in that regard, and now even having teachers being the possibility, particularly in middle-income countries, the possibility of teachers being vaccinated, then in that regard, having school closed as part of the arsenal, right, of fighting the pandemic, right? Obviously, I'm not talking about the schools being open as always, right? It's complicated to implement the social distance or social distancing. I mean, measures. All kids should be masked. So it's not easy. I'm not saying that that's not easy. But then if countries undertake those complex, right, opening processes, then, I mean, the benefits on the health side of keeping the kids out of school are very low. The costs of keeping kids out of school, the cost for children in terms of losses of learning, right, in terms of mental health, in terms of lack of socialization, those we know are very high. Right, so that's the issue, right? That's the issue in terms of now with the evidence that we have today. Then, in terms of cost and benefits, right, for students and for teachers, right, the benefits are low of keeping kids out of school, but the costs are very high, right? So and despite that, right, we see very different positions across countries, right? In some countries, middle-income countries, you see a very aggressive return to school, right? And actually leadership of ministries of education say we need to return to school. And in other cases, no, basically kind of a paralysis and inaction and say, well, let's wait, maybe next year, things might be safer. Things are too complicated as of now. So very, very different positions despite the evidence that we have.
Patty, can I jump in on that?
Yes, Chris, please.
So first, I agree with Jaime that it's a good idea to open schools when appropriate mitigation's in place. But it's, you know, the studies from pre-Delta to Delta aren't not useful, right? Because some of this, you know, the Delta variant is so much more transmissible. And we've seen, for example, in Scotland, without appropriate mitigation, without mask use in elementary schools, you know, fueling a second Delta wave. So we have very clear evidence that school-based transmission, and there's tons of these studies now, can take place. So it's not really quite as simple as saying, you know, pre-Delta, there were some studies that said there wasn't a lot of transmission. If you look at seroprevalence surveys, the cumulative infection rate in kids is the same as adults. So there's, on average, you know, you can point to one survey or another, but if you take the meta-analysis of them all, there's no evidence there's less transmission in kids. It is true that the death rate is much lower, but the question here is the role of children, as in Scotland, of fueling a general increased wave of transmission. But it does seem that at least in the US and in other countries in Europe, if you have the mitigation in place, you don't. The question mark, I think, comes of the danger there is to sort of make the more general pronouncement that kids don't play a role in transmission or a substantial role.
Well, before, I think it's good. It's a good thing to argue. We like not argue. We like discussions. So I'm going to give Jaime a chance to respond further. But I will say one thing, Chris, when I put you on the spot again about something, it's not just about what happens in a community. It's the dose response curve in a household. Because risk mitigation in a household in the absence of vaccination becomes extremely difficult. And so some substantial amount of transmission can be seen in the household. The question is, does a child who comes home with asymptomatic infection, what risk do they represent to a household and multi-generational adults? Now, I mean, this is a tough question, you know, because we and others have done a lot of household studies and looked for these kind of dose response curves. So I think, again, I think it's very complicated. I mean, everybody on this call probably wants to put kids back in school. There's no doubt about that. The question is, what are the costs? The benefits are obvious too. And this debate about the cost extends further. So I mean, we're gonna put you back on the spot. You can have the last word on this. You get the last word.
No. This is as you say, this is where we're battling a war right here, and battling a war is very complicated. So, and actually the information that we have in order what works or what doesn't during this war evolves a long time. But despite things evolving, we need to take decisions, right? But it's true. It is very difficult. Now, meta-analysis, I mean, are really varying from one month to the other. That's one thing. And second, the other thing is that schools one thing is to have the analysis of what happens when schools are opening, but actually other things in the economy are opening as well, right? Actually one will have to isolate, say what happens that only school systems open while all other things are either closed or already have opened before, right? We see many economies in which you have restaurants, factories, stores, malls opened, and school closed, right? And let's say, what is then the school system, right, going to be a major factor or an important or a factor, right, of then fueling the disease? Most likely not. However, given that we do not have clarity, right, it is absolutely essential that when we do that, right, we need to use masks, we need to use social distancing. In the transportation issue is very complex, right? Actually, you will need to take the hard decision and say this kids should go to the school that's closer to home, right? Not to any school. Is that easy? No, it's not. That's not easy. But I mean, we're talking about battling a war here, right? So no policies here are simple policies to implement, right? But I think it is doable, right, to implement those sanitary precautions, right, and then make sure that what happened not make sure, but minimize the risk. That's something that, like the example of Chris that was mentioned in Scotland, does not repeat. My point is always sometimes school systems, yes, but it's difficult to make sure that all kids use masks. Yeah, of course it's difficult, but the public policy is full of difficult things, right? It's difficult to make sure that there's water and sanitation in all schools. Of course, yes, it's difficult, but it's not impossible, right? So actually, there has to be a real effort of countries of recognizing, look, there's huge costs on kids. Then we need to implement those complex policies, right, that will assure that or minimize risks when kids go back to school.
Thank you, Jaime. And we're getting the picture, right? There are countries like Peru in which gyms, movies are open, movie theaters are open, but schools are not open yet. So it's like also trying to make more sense about opening of the economy and not opening of schools. So we have reached almost the point of closing this session, but I would like to give you all a last question, if you 2 minutes to answer, okay? So because all of you have highlighted that the impact of pandemics on health, education, ability to work outside of home, and the economy are highly interrelated. So what would each of you would say will be the top 2 things we should do differently in preparing for or dealing with future pandemics, okay? And maybe we should start with Erica, the historian, okay? Let's go backwards this time. Erica.
So obviously in one way I would say predicting is full of pitfalls. And so I think to me, one of the points that if history is going to encourage us is to think about humility and the limits of our knowledge, especially our ability to predict. But I think the other point I would say is when we're in the crisis, it's very hard to know what we think is important. And I think one of the points I see even in the discussion today is that we're debating about different things that we want to measure. And it strikes me that one thing to think about is what we're measuring and what we're focusing on, because obviously what we measure then determines what we think is important. But there's a variety of things that we could be measuring at the time. And so it strikes me that, right, we tend to think of this in terms of medical terms, but I think a lot of the talks today have reminded us that there's a multitude of things that we need to measure. And if we're not measuring them, then sometimes it takes us quite a long time to realize the impact of what's unfolding.
Patty,
Sorry.
you're muted.
Yeah, sorry. Stephanie, go ahead.
Sure. I think, I guess, picking up from the last question and then what Erica just said, I think one lesson would be looking and appreciating at the full costs and benefits in trying to put in place kind of an adequate policy response. And we've talked about additional costs here, whether it's related to mental health, but also looking at kind of second and third order effects of the enduring costs from the pandemic. And that goes to the second point. and the focus on the preparedness and prevention. I mean, we know that the costs from this pandemic will be in the multiple trillions of dollars. And I think trying to address the problem ex post, when really the most efficient way to get at the issue is ex ante, and really putting the financing into that prevention and preparedness is really where we need to focus the discussion and hopefully focus policymakers' attention.
Thank you, Stephanie. Jaime.
Thanks. Let me see. Yeah, thanks, Patricia. So, two issues. One is that we're extremely worried about the inequality impacts that this pandemic will have. As again, as Erika was saying, right, the pandemic sometimes reinforced tensions that we had in the past, and many low and middle income countries already had gigantic inequality of opportunities. That has been exacerbated by this pandemic, in the sense that educational opportunities have been, during the last year and a half, in middle income countries, totally correlated to your level of wealth, right? And the equalization impact that schools have disappeared, right? And we really need to work in terms in the coming months and years in order to try to ameliorate that impact that this will have, particularly among the poor. And when I say the poor, I'm not talking about the bottom 10%. I say probably it's the bottom 80% against the top 20%, right? And so that is a huge shock that might have impact in the future. And my final point is that in order to address that, two things should happen. One is we'll need to close the digital divide. That we knew before the crisis. Now it's even more evident, right, that has to happen in order to have more resilient school systems. But second, we need to recognize that education is a social endeavor. So actually the interaction with teachers is what really generates learning, and that requires then a completely different level of investment in our teachers. Right? Because I mean, even if we say at the same time that we need to close the digital divide, the future is going to be about the art of balancing technology with the human factor. The future will be precisely about more empowered and better trained teachers that can use and leverage technology more efficiently. Over.
Chris.
Thanks, Patty. First, I think that we've learned through the pandemic so far that it's behaviors and what drives human behavior that's the critical determinant of having a big epidemic or a small one. We all tend to focus on the biology. People who do modeling tend to focus on transmission patterns and R naught and things like that. But what really matters in the long run is things that drive people's being careful, wearing a mask, whether they want to get a vaccine. And we need to learn a lot about what drives behavior and why it's been so different in different parts of the world, so that we can, hopefully have in the next version of a pandemic, behaviors that are going to reduce transmission faster. Second, we've learned the harms of data hoarding by government, including in the US, and we really, really need to somehow overcome the natural instinct of governments to want to not share data with the public or with the scientific community. And that just puts blinders on everybody, because we do need everybody in the country, in the globe, putting people's best minds to the task of figuring out how to tackle a threat as it emerges. And if we don't have access to data, that just is a super profound problem, and one for which I don't see a huge amount of progress so far, and hopefully we will see progress for the future.
Well, thank you so much to all our speakers. It has been really wonderful. We have seen what data is showing us about COVID, and as it has been said, I mean, we can have models, but what we are not doing is understanding what are the behaviors behind the numbers. We have talked about education, which is a critical issue, and we need to work on issues like the digital divide, the participation of parents, education as a social issue, and the participation of communities. Stephanie has highlighted the importance on the preparation to think about financing and to think how pandemics have really widening the divergence in the countries. And with Erica actually trying to put everything together, it's not that easy to say when a pandemic ends, because the ends can be multiple. Like you gave the example with Ebola, right? Depending on what you think it is, but in reality, we have to see that the pandemic is not only a biological problem, it exacerbates other issues, social, economical, and problems, discrimination, inequalities that already exist. But from the very beginning, there is a mixture of things going on. So we, instead of looking at pandemics like just curves of one disease, we need to put together several other factors. So thank you so much to all of you. And now, please, Myron, it's your turn.
Well, my turn is going to be really, really brief because the room has to close in exactly 3 minutes. So let's see. I'm going to say in the next 3 minutes first, on behalf of Judy and Patty and I, we want to thank the speakers and the National Academy audience and the public audience who, if they have questions, can send them directly to speakers of the National Academy. Let me also thank Jamal Samuel, Julie Lau, and Amici Pavi, who I always have trouble with that name, for all their technical and other help to make this session take place. What I would say is, just to summarize, is this was kind of exceeded our expectations in the sense that we had in one session all these really smart people talking about Thucydides and debt suspension in the same session. And you know, that's not that often that happens. I also learned about Mission Recovery 2021, which would never have happened had I not participated in this program, which I think is a really exciting way moving forward. I think that from Chris's talk, I'm going to end this session on Chris's talk in a sense. You know, he talked about the methods he's applied, and he's got his optimistic modeling curves, but then he has this giant caveat. And the giant caveat, so if you listen to Chris, who I know quite well since we're on committees together, his giant caveat, well, the virus, we don't exactly know what the virus is going to do. And our species is very diverse and unpredictable, and we don't know what the species is going to do. And so it's hard to predict the species behavior in the context of vaccination and what happens to the virus. So all the curves are in many ways dependent on variables that don't exist today. So I think that from Chris's talk, which quite brilliant as always, was that what is predictable that we are, and from Erica and Chris, I would say, this is going to go from a pandemic to multiple small epidemics to an endemic disease. This is going to happen. We just don't know when it's going to happen. We don't know exactly where the epidemics are going to be, and we don't know how severe the endemic disease is going to be that we're going to confront as a species. So I want to end exactly at, because I know the room closes, I'm done exactly at 119.3. Say thank you really all so much for participating. Thank Judy for her leadership, and good afternoon. Thanks. Bye.